Nirav?
Yeah, that was fantastic talk. I need to understand more about the indications for opening a long segment carotid occlusion. Am I to understand that if the carotid artery, the ICA, has been occluded for a week or 2 weeks or 3 weeks, you're going back and opening that carotid? And if so, does it have to have some sort of retrograde contrast coming down first? Just if you could tell me a little bit more about which carotids you're opening in a delayed occlusive fashion.
Dr. Wang.
Oh, yeah. Thank you.
王教授，他问你就是，通常闭塞长段的闭塞以后，你要不要看一下远端的那个反流的情况？通常要在多长时间里面把它打开，再通？
Yes, certainly. When reopen the occlusion, the successful depend on the distal ICA, whether it is a ranunculus cavity, whether it is open. So the distal is fantasy is the key to open the occlusion.
Yeah, normally I can introduce our experience. Normally we will use blood vessel, so-called black flow sequence to measure the distal condition of the ICA. Yeah, if it's still patent, you can recanalize it. If it's already totally occluded, approaching to the paraclinoid segment, it's impossible to recanalize. Yeah.
And so, okay, that makes a lot of sense. There needs to be some retrograde filling down to the petrous segment or something you can see, then we can redo it. And even in a delayed fashion, 1, 2, 3, what's the longest you can, it's okay.
Dr. Wang, what is the material? Is it Gore-Tex, the artificial vessel? What's the material? What is it made of?
It's a Gore artificial made in USA.
Gore-Tex, yeah?
Yeah.
And dual antiplatelet therapy for treatment? What do you put the patient on? Antiplatelets?
No.
Nothing? No
Yeah.
aspirin, no Plavix, nothing?
Sometimes if we prevention the thrombosis, we can use aspirin, and not always.
Are there peripheral vascular surgeons in your region who do the same thing? I'm impressed that neurosurgery has taken this. Are there peripheral vascular surgeons who also do these operations in China? Oh, I know that, but I'm wondering, are there, separate from this practice, peripheral vascular surgeons who do this in some unit? It depends on the unit you're in. Okay.
But more by neurosurgeon.
More by neurosurgeon.
Yeah.
Well, that's you should teach us in the US how we can reclaim that. And the question, I was going to ask Kiko, and go ahead.
I'd like to make a comment. For the occlusion of the vertebral artery, most of the time, doing a bypass like this is not necessary. The best way is just to transect the vertebral artery to make reimplantation back to the carotid artery. So that will become a branch of the carotid artery. This kind of surgery will be much easier than an artificial graft bypass.
First done in 1953 in Chicago, what you just described.
Okay. I'm sorry, I didn't.
Can I ask you two, maybe, do you use, I'm going to call it the Yazargil technique of taming or bipolaring complex aneurysms to make clipping easier? I use it routinely for tough aneurysms. It really makes clipping a lot easier instead of ending up with complicated constructs of clips, you tame it, you bring the base down, and you showed one case, I probably would have bipolar, then clipped. Comments on bipolar coagulation, careful under irrigation, bipolar coagulation of under temporary clipping, by the way, always, if you're going to do it. Just any, or the moderators to anybody.
Sometimes I do it, but only on a small aneurysm, not a very big one. Small, complicated aneurysm. Try to trim the configuration of the aneurysm to enable a clipping. But for a very large one, that will be useless.
Can I, Young Guang, can I just ask you one question?
Yes.
Have I mean, very nice, obviously, President, very large experience. But today, if you have a carotid cave or a clinoidal aneurysm, not the other two, wouldn't it, I mean, it's not, if not giant, if it's small aneurysms, wouldn't it be better to do by flow diverter rather than going for this microsurgical clipping? The clinoidal and carotid cave aneurysms, small, I think today they are better managed by endovascular. I mean, the risks are much less, the complications are less. Yeah, but no,
Yeah.
if they are symptomatic, if the patient has pain or ophthalmoplegia, they are candidates for treatment. Small, of course, they have to be left alone. But some cases he showed with a little bit of intradural extension.
Yeah.
And the ones, the carotid cave. But I think if there is small aneurysms which are not giant, which is not producing a visual deficit, a mass effect, I think in my practice, they would go for endovascular, whereas the pure ophthalmic, the blisters, they are microsurgery in my practice.
But endovascular surgery, I believe the complication rate is higher. They have a much higher complication rate. With this type of surgery, we do not have any mortality. We had mortality years ago before we used the hybrid OR. But in recent 10, 20 years, we never have any mortality. However, using the flow diverter is easy, but they still have a higher mortality rate. This is one thing. I don't know. You need to use antiplatelet and anticoagulant, and it cannot be done during acute hemorrhage. So
maybe I may comment on that because this was a big debate in the European Stroke Organization guidelines that we published. And I agree that, and everybody knows that I love clipping, but for proximal carotid artery aneurysms, the data on flow diversion is pretty solid. We debated about it significantly for the recommendation of the use of flow diversion versus other modalities. But for proximal carotid aneurysms, the data is quite good. And I think the outcomes that you cited, they're a bit historical. Now we did a new meta-analysis for the German guidelines because the German neuroradiology community really fought against the recommendations against flow diversion as a primary strategy. And I must say, yes, it's more complex and it's more riskful than simple coiling. But in the case of proximal carotid aneurysms, they're still better than surgical treatment.
Can you comment? Drop my partner, that's all. And it's very important. What's your standing on this?
I think the complication.
Microphone.
The complication risk associated to the flow diverters, the average is about 7 to 8%. And that mostly related to some sort of a rethrombosis, which is related to drug resistance and potential knee rupture risk actually is very low. So the overall, particularly I agree with Nima, that in the cavernous segment, proximal segment, there are no perforator whatsoever. As long as the patient is able to tolerate the medications, meaning Plavix, aspirin, or same group of medications, the flow diverter had very solid data. And compared to surgical risk complications, I think at least for us, we felt very compelled that flow diverter treatment is a better option. That's how we feel at this point. And I think general data also point that quite clear.
And maybe, I mean, we see a dangerous trend in Europe, at least, that I see a lot of secondary opinions, and like the neuroradiology community proposes treatment of 3 millimeter paraophthalmic aneurysms with flow diversion. And that's, frankly, that's a complete ridiculous development. And these are young women who want to have children, etc. So dual antiplatelets, if that would be, and honestly, those aneurysms, I would propose clipping if there's a indication for clipping in an irregular configured hypertensive patient. So I agree with you that for paraophthalmic aneurysms pointing laterally, there's a difference, but like partially extradural aneurysms.
Yeah, Dr. Sami.
Two questions to all of you. I had difficulties in giant ophthalmic aneurysm. Once when the neck was sclerotic, and I wanted to put, and I saw I cannot close it because it was very sclerotic, the neck. My question to you, how you managed that? The second one, which I had to learn, was the pressure of this neck aneurysm was so high that any type, even scalpel clip and all large clip I took, and the pressure slipped then the clip out. And then I came to the idea, at that time, Professor Valavanis, he took a catheter and make a temporary occlusion of the carotid, and I could do it fantastic to clip and solve the problem. Did you have two questions? Please tell me how you have solved the problem.
For me, these questions are, I think, very clear in most of the people, because the problem of the pressure is suction, the compression. Most of the times, there is not that a huge problem. It's suction decompression, and when there is calcium on the neck, we consider always a bypass first, because we are very likely to occlude the ICM. It's the point. You might be very lucky sometimes and you're able to clip it, but the problem starts 2 weeks, 1 month, 7 months later. It's clear. And the of course. But you first, if there is calcium on the neck, you put the bypass, and then sometimes you can do it with fenestrated. And the other two questions, one, the proximal, for me, the paraclinoid, it's clear, as I said in my talk, if they are traditional ophthalmic aneurysms, you can get total decompression. And I think the visual preservation, because the worst thing that could happen drilling the clinoid or things like that, there are a lot of reports in the literature, you can damage the optic nerve. It's not our experience. It's not our experience at all, because we changed, you know, Rokuya Tanikawa, I saw I've been there with them a lot of years. They published that they had, I don't know, they checked the vision like hell. It's maybe we are not that accurate checking the vision, but they changed to using rongeurs. And we designed rongeurs to do that, and it's very easy to do that extradurally. They used to say that. I've never seen that in my life. When I was a resident, I listened to, in Spain, Roberto Eros, and said that you were very likely to cause problems with vision drilling, but it wasn't my experience. I usually clean and you irrigate. This is not the problem. Yeah. And for me, these aneurysms should be, the regular ones should be clipped if you have technique to do that. Of course, flow diversion is an alternative. For the carotid cave, we are pretty conservative with this, because even with a flow diversion, sometimes you might have pituitary problems because of the superior hypophyseal,
And this is a point. Of course, flow diversion is much safer than we used to think, because they said 14% or something like that is not true. It's really safe. But on the other side, I've operated on very small themes with a flow diverter, and the theme ended up turning into a giant something in this region. So be careful with be conservative, as you said.
Okay.
Okay, end here and should break and then move on to the next. Oh, well, I'm sorry, Dr. Sami, okay.
Thank you very much.